my name's Kim. Today I'll be performing a Cardioversion simulation OSCE. We've been dispatched to a 55-year-old male who's been complaining of chest pain and sudden collapse. The earlier history of today is that he had chest pain and he was unable to stand due to dizziness. He has a past medical history of hypertension, ischemic heart disease, and he had a myocardial infarction 5 years ago. Prior to his collapse, he stated that the chest pain felt different to normal. He also takes cilazepam and aspirin as his cardiac history medications. When we arrived today, the patient was lying on the floor. His airway was clear, his breathing was adequate, increased but adequate. He had a rapid carotid pulse. He was pale and clammy. His eyes were responding to pain, and his only verbal response was to shout out in response to pain. A full list of vitals were obtained, including a 3-lead and a 12-lead. His 3-lead and 12-lead showed ventricular tachycardia. His blood pressure was 70/40. His heart rate was 170 a minute. His rest rate was 24. Blood glucose was 7.6, and he had a temperature of 37. So my next step is to determine his level of compromise. So I'll ask the patient to squeeze my hand. Sir, can you squeeze my hand? Sir. So the patient is unable to obey commands as he's unable to squeeze my hand, coupled with his severe hypotension, his increased rest rate. He looks status 1, like he's pre-arrest, and I've deemed him severely compromised. My next step would then to be called to radio for R54 ICP backup for a status 1 patient in VT. Due to his presentation, I've prepared my gear in case of an arrest. I have positioned the patient supine. I have my suction ready, my bag mask ready to go, high flow oxygen attached to the patient. My monitor is in manual mode, and I have bilateral large bore IV access. As the patient is in VT, I need to consider some secondary causes. Infection can cause electrical imbalances within the heart. As the patient is afebrile and has no recent history of infection or being unwell, it doesn't contribute. I've ruled that out as one of the causes. Hyperkalemia can also cause electrical disturbances. It is quite difficult to differentiate between SVT with aberrancy and VT. However, SVT with aberrancy is rare, and it's also rare to cause severe compromise. The patient is more likely to be in VT if there is an absence of bundle branch blocks, a presence of extreme axis deviation, AV dissociation, or fusional capture beats. We're now going to go through the procedure of cardioverting the patient. We need to redetermine his level of compromise, ensure that he is still unable to obey commands. Can you squeeze my hand? There's no response, he is still unable to obey commands. As he is still severely compromised, he does not require sedation. If he were able to obey commands, we would need to call for backup or call clinical desk for out-of-scope ketamine. Going through my checklist, I'm going to get my off-sider to do a challenge response technique. My off-sider will read out the checklist to me, and I'll confirm the actions as we go.
Cardioversion checklist. 1. Place pads in either the apex, sternum, or anterior-posterior position, in addition to ECG electrodes.
The pads are placed in apex sternal position. The ECG electrodes are on.
Okay, 2. Ensure the defibrillator is in manual mode.
Defibrillator is in manual mode.
3. Select a lead with a visible R wave and ensure that artifact is minimized.
The best lead is selected, and there's no artifact.
4. Select synchronized mode.
Synchronizing. Synchronizing. Yep.
6. Confirm there is a detection symbol above every QRS complex.
I'll print out a rhythm strip to ensure that we've got a detection symbol above every QRS. We have a detection symbol.
7. Select the joules, charge the defibrillator, and confirm everyone is clear.
Joules, maximum joules are selected, in this case 200 joules. Charge, monitor is charging. Everyone clear?
8. Press and hold the shock button until the shock is delivered.
Clear, press and hold, shock delivered. Once we have shocked the patient, we will then print out a rhythm strip to double check if we have any revision. The patient is still in VT. If there hasn't been a revision, we then need to do another cardioversion. We need to check if further analgesia is required. We will need to resync and confirm the detection symbols and re-go through the whole cardioversion checklist. If we have attempted to cardiovert twice and there's been no revision, we need to transport the patient towards backup or towards hospital.